So opioid analgesics. Analgesics are things that decrease pain or stop pain. But kind of like on the whole, pain is good. It warns us when something's wrong. It helps us identify where those wrong areas are. And they stop us from using that area so it can heal. So like, if you have a splinter in your finger, like if you touch something, you're like, ow, that hurts. Maybe I shouldn't do that. Or maybe I should remove that splinter. And then you're not going to use that finger for a while until it starts to heal up. But pain can also severely impact your ability to function. And in that sense, it's not good. And on top of that, like the psychological strain it puts on the body can slow healing, causing depression and a lot of other stuff. So pain is good because it lets you know where the problem is. It might stop you from using whatever is hurt, but it's also not good. And so we have analgesics. Opioid analgesics treat moderate to severe pain. So these are used in cases where you need a lot of pain-stopping power, okay? So areas of trauma like broken bones, big wounds, if you've had a myocardial infarction, which is like a heart attack, terminal illnesses like cancer, you get opioids to treat those. So pain, you have nociceptive pain. This is stimulated by the peripheral nervous system and then recognized in the central nervous system. So you do something like get a splinter, and you have these nociceptors, these free nerve endings that realize that tissue damage. There's a lot of different ways, like free ATP or phospholipids or whatever. You have these nerve endings that pick up on that and then release this neurotransmitter called substance P, or this neuropeptide called substance P. That then comes up here to the central nervous system, releases in the dorsal horns of the spinal cord, goes up to your thalamus, which is kind of like the relay system for a lot of your sensory inputs, and then out to the cerebral cortex, where your brain associates that pain with an area of the body, right? So you can have neuropathic pain. That's when the nervous system is damaged or not working properly. Neuropathic pain is always chronic pain. So something like sciatica, pain in your sciatic nerve, you're always going to have that. It's not acute. Acute pain is pain that goes away with time. So your splinter is acute pain. You're not going to feel that splinter for the rest of your life. That would be chronic pain. You can also have hyperalgesia or super pain. It is an over-responsiveness to a stimulus. This can be induced by barbiturates. So some barbiturates can cause hyperalgesia, where your splinter typically would be like, ow, that's really uncomfortable, to where you touch it and it is a searing pain and you feel like you're going to die. You also have referred pain. So pain in an area that is not injured. This is something we see with heart attacks, right? You'll have pain radiating down that arm, or pain in the chest region, maybe up in the neck. That's referred pain. With kidney issues, people feel pain like in their lower back, not specifically in the kidneys. Referred pain, you learn about it in physiology, so we won't go a lot into that, but it is a type of pain. In this group, we're going to be talking about opioids, but opioids do a lot of other stuff besides just analgesia. So pre-oxidation and fentanyl, like we just talked about. They also are antitussives. Antitussives are things that stop you from coughing. So there's centers in the medulla that get triggered, when your bronchioles or your trachea has irritants in it, and then you cough to get rid of whatever that irritant is. Antitussives like codeine stop that from happening. They downplay that. And so while the issue's still there, you don't have that reflex to want to cough. Also, antidiarrheals like Imodium is an antidiarrheal that is an opioid. When the opioid epidemic was really bad, I saw news stories where people were buying up a bunch of Imodium and taking Imodium because it is an opioid to get their fix. And then, of course, you're going to get super constipated. So, not all of our opioids are created equally. Some are better than others. Depends on your term better. But pretty much the gold standard is morphine. Everything is based off of morphine. Morphine is highly addictive. It is a really good painkiller. It is a good antitussive. And then from there, you can either be more or less addictive, more or less of a good painkiller or tussive, like on the scale. But typically morphine is like, all right, we're going to set it here, and then you're either better or worse than morphine at these things. Like codeine and hydrocodone, they're much less addictive than morphine, still pretty addictive. They're not as good as killing the pain, and but they're pretty good antitussives. And so you see it in a lot of prescription cough medicine. You're going to have codeine and hydrocodone. Oxycodone works the same as morphine, so it's a good painkiller, it's a good antitussive. It is also addictive. Methadone works the same as morphine, except it's less addictive. And so you see a lot of people who have become addicted to opioids. They might go to methadone clinics where you get methadone to step down off these opioids so you don't have withdrawal symptoms, which we'll talk about. And then we get into stuff like oxymorphone and heroin, which are super, super addictive, like more addictive than even morphine, and even better at killing pain than morphine. We don't have any info on their tussiveness, on if they're a good antitussive or not, because it's typically not used in that sense. Coughs are not bad enough to require the use of oxymorphine. And I don't think anyone has been like, oh man, I have a really bad cough, I think I'm going to take some heroin. Yeah, that doesn't happen. Right? Something that you might see in here is the better it is at killing pain, the more addictive it is. And we kind of see those two go hand in hand, except with like methadone here. Funny story, heroin was produced from morphine. So doctors realized that morphine was really addictive but good at killing pain. They're like, well, we should make something that is similar to morphine, but less addictive. And they ended up making heroin. And they're like, hey, guess what? It is better at killing pain than even morphine. And also a lot more addictive. So, kind of missed the mark on that one. Alright, so all of your opioids are central acting analgesics. Like, their primary focus is in the central nervous system. There is some peripheral function, which we'll talk about, but a lot of the effects are in the central nervous system. The DEA, or the Drug Enforcement Agency, has categorized most of your opioids as Class 2 drugs. So the DEA has a big old list of drugs that are classified in different classes. Class 1 drugs are stuff like heroin. Drugs that are highly addictive but have no medicinal use, at least in the United States. So a lot of your illegal drugs are going to be Class 1 drugs. It's like they will mess you up and there's no medical reason for it. Class 2 drugs are also highly addictive, but have medicinal uses, like morphine, like, oxymorphone, where, yeah, these are really addictive, but there is a use for them. Some of your opioids are even class 3, class 5. So like Imodium, right? You can get that over the counter. That's not a problem. Some cough syrups have an opioid in it that you can get over the counter. It's not very addictive, but has been abused in the past. All right, so how do opioids work? Well, they help you tolerate pain better. They don't make the pain go away, right? They soften it. They make it not as severe, but it's still there, right? Your opioids, we knew that they worked for a really long time as painkillers, right? Morphine has been around for a really long time. Heroin has been around. Opium has been around for a really long time. Great at killing pain. So we knew that opioids worked at killing pains, but we didn't know how they worked until we found endogenous opioid receptors. For a lot of this stuff, it's like we knew the receptor and then we made the drug. Opioids, we knew what they did and then we found the receptors. And there's a couple different types of opioid receptors, like mu, kappa, and delta. You can have a couple different types of mu. But your endogenous opioids, like endorphins, naturally bind to your endogenous opioid receptors, and they're actually a lot more potent. So your mu1s, they interpret your pain. Mu2 does analgesia. Euphoria. Euphoria is this just feeling of good, of wellness, of happiness. Mu2s are also responsible for your respiratory depression, which is the main way that opioid overdose kills people, and the physical dependence on it. So these opioids decrease pain, but pain is weird. The central nervous system can see a painful situation and interpret how painful it's supposed to be before you even get hurt. And so it can potentiate this pain before it even happens. It's based on this preconceived notion of what the pain should be. And then if you're anxious about something, it can cause that pain to go even higher. This is something we see in people who have shot anxiety. It's as they're freaking out about it, when it happens, the brain is yep, we knew that was going to be bad, And so the body responds with extra pain. You experience extra pain because you thought you were going to experience extra pain. It's just, the brain is a weird place, man. It predicts how bad something's going to be and makes it that bad. Or how not bad something's going to be. So you'd be oh, this isn't going to be bad at all. And you do it and you're yeah, I was right. Just because your brain downplayed it because it didn't expect it to be bad. Crazy place. So when we're looking at how these opioids work, looking specifically at the mu opioid receptors here, if you're in the primary afferent fiber, so this is a sensory fiber coming from wherever your stimulus is to the central nervous system, you have your mu receptors all along this axon, right? All along this neuron. And what it does is it stops calcium from coming in. So it stops the inflow of calcium. And so that means this neuron won't release glutamate or substance P to stimulate the next neuron. And so you're stopping the signal here. You're also stopping the signal here. So these guys meet up at the dorsal horn in the spinal cord. So this is a peripheral nerve coming into the central nervous system, into the spinal cord, and then this one would go up to the brain. Even if substance P and glutamate get released here, your mu receptors on the secondary afferent neuron open up potassium channels, and so potassium is flowing out. So this stops the depolarization from happening because it's blocking calcium from coming in. It's stopping that depolarization. This is stopping the depolarization by letting out potassium, and so it's hyperpolarizing on this side. Something you may have heard of is naxolone. It is an antagonist to these opioid receptors, and so where your endogenous opioids or opioids would bind to these mu receptors, naxolone binds instead and then stops those from binding, and so things return to normal. And it's really important, again, when we're talking about your respiratory depression. Alright, so why opioid analgesics primary action is in the central nervous system, you find opioid receptors throughout the peripheral nervous system too. You know how mu can cause euphoria, like that overall good feeling. Kappa can actually cause dysphoria, and dysphoria is an unpleasant feeling, like one of fear and anxiety. Mu's able to do euphoria because it inhibits GABA, and GABA helps regulate dopamine. And so if you're down-regulating the thing that regulates dopamine, you get more dopamine, which gives you the euphoria. So at low doses, most opioids can produce nausea and vomiting. That's due to the delta and kappa receptors. But at high doses, mu actually inhibits the vomiting center, and so the nausea and vomiting goes away. It also inhibits the smooth muscle peristalsis via spasms, and so you're not getting things moving through the intestines, and so constipation is a pretty common side effect for anybody who is taking opioids, be it like hydrocodone or morphine or heroin. Like, it does that, and sometimes the spasm can cause cramping. It also stimulates ADH. If you remember what ADH is, it's antidiuretic hormone or vasopressin. And this can cause oliguria, which just means less than the normal amount of urine produced. And so you're producing smaller urine volumes. Again, side effects, constipation is one, confusion's another, somnolence, this is sleepiness, you feel sleepy. Methyl-naxtrexone or Relister can reverse the GI effects, and so it can get rid of or counteract the constipation that a lot of your opioids can give you. Alcohol is synergistic because it also depresses the central nervous system, and so when you are on opioids, you should avoid alcohol and alcoholic products because you're enhancing the depression on the nervous system. And this is especially important for those respiratory centers that tend to be the main reason people die from overdoses, right? And a few of the opioids, like dextromethorphan, is potentially fatal when combined with MAOIs. MAOIs are monoamine oxidase inhibitors, and they are contraindicated, meaning do not take these two things together because bad stuff happens, right? Something that we know about opioids is that people get addicted to them, right? This whole opioid epidemic is because people become addicted to opioids. They have been overprescribed. You also develop a tolerance to opioids. So as you take them, You desensitize mu and kappa receptors so they don't respond to those opioids as much as they used to. And so you got to take more. Problem is, not all tolerances build up at the same time. And so as you're taking them, the pain tolerance might build up a lot quicker than the respiratory depression tolerance, right? And so you take your same amount, you're still feeling the pain, but your respiratory is still being depressed the same amount. And so you really gotta be careful with the tolerance on these. Withdrawal or abstinence syndrome happens about 72 hours after your last dose. So if you do become addicted to opioids, about 3 days after you took it, you are going to start experiencing withdrawal symptoms, which includes sweating, yawning, restlessness, tremors. And then as it progresses, as the time goes since your last dose, you start getting more irritable, start getting vomiting and diarrhea. You might even get goosebumps and chills and even skeletal muscle cramps. So addiction and physical dependence are different things. So this is showing physical dependence. This is your body responding to the lack of this drug. Addiction is a complex interaction of your genetic predisposition, your psychology, your physiology, the social environments that help to describe this behavior of addiction. Something that we see in cancer patients, so they're on, especially like terminally ill cancer patients, are on a bunch of opioids, and they go through an opioid rotation. So that helps to fight some of that tolerance buildup and physical dependence buildup in these opioids. And again, methadone is a great way to step down off of an opioid addiction because it satisfies that craving, but it's not as addictive, so it helps to break the cycle. Alright, so if you don't know what an opioid is, now's your chance to ask. We will pick up with non-opioid analgesics in the next section.